হ্যালো হ্যালো কেউ দেবে না না আচ্ছা সবাইকে আন্তরিক শুভেচ্ছা তো সবাই সুস্থ থাকো এবং আমরা আমাদের সাপ্তাহিক যে ক্লাস মেডিসিনের পক্ষ থেকে কোশ্চেন ডিসকাশন এটা আজকে সিবিএস এর উপরে আমরা 5টা কোশ্চেন আলোচনা করব এবং তোমরা মনোযোগ সহকারে কোশ্চেন এবং তার উত্তরগুলি সংরক্ষণ করবা এবং এইভাবেই প্রিপারেশন নেবা নভেম্বরে তোমাদের পরীক্ষা তো ফার্স্ট কোশ্চেন a 50 years female come with the complaints of convulsion, blurring of vision and disorientation for last 4 hours. On examination, her BP was 220 by 130 millimeter of mercury. What is your clinical diagnosis? Clinical diagnosis was hypertensive encephalopathy. Next question chilo, were mention the investigations with findings of this patient. The investigations are your random blood sugar to detect diabetes mellitus, serum creatinine to exclude renal failure, and ECG to detect LVH, which is characterized by S in B1 and R in B6, more than 35 millimeter, and ischemic heart disease characterized by T inversion and ST depression. Serum electrolytes to detect hyponatremia, and echocardiogram to detect LVH and ischemic cardiomyopathy, CT scan of brain to exclude stroke, and ophthalmoscopy to exclude papilledema. So this is the investigation for this patient. Now treatment. Treatment first hospitalization of the patient and specific treatment your maintain ABC, airway clearance, breathing by oxygen inhalation, circulation by opening IV channel, then injection diazepam 10 mg IV to relieve convulsion, and followed by tablet difedan or phenytoin 100 mg 3 tab daily continued. And to control blood pressure, injection labetalol 100 to 200 mg IV to control BP, and injection prosamide 20 mg 1 to 2 ampoule according to need to control BP. And other general measures are catheterization and nasogastric tube for further medication and your feeding. So this is the treatment of this patient. Now we go through the question number 2. A 25 years old female presented with progressive dyspnea and palpitation. On examination, her pulse irregular with apical mid-diastolic murmur. What is your possible diagnosis? Here the possible diagnosis is mitral stenosis with atrial fibrillation. Our next question, how will investigate this patient? And the investigation of this patient is ECG P mitrally, which is characterized by broad P wave in lead 2 and RR interval irregular, absence of P wave, and P wave replaced by fibrillatory F waves. Next, X-ray chest which will show straightening of the left border of the heart, double contour in right border, widening of the carina, upper lobe diversion, that is upper lobe vessels are prominent, and transverse diameter of the heart is increased in case of mitral regurgitation. And finally, echo will show narrowing of the bulb, thickening of the bulb cups, hypertrophy of the ventricle, and regurgitant blood flow due to MR detected by color Doppler. Now, how we'll treat this patient? The treatment is medical treatment followed by surgical treatment. Among the medical treatment, diuretics, furosemide, digoxin, especially for atrial fibrillation, AC inhibitor, ramipril, antibiotics, phenoxymethyl penicillin, and 250 milligram, one tab BD up to 42 years. And next, low dose aspirin, 75 milligram, to prevent stroke and thromboembolism, and warfarin in case of stroke and thromboembolism. Now, surgical treatment. CMC, closed mitral commissurectomy, indication isolated MS and cups are not calcified. Second one is mitral valve replacement, and indication is associated MR with MS, and valve cups are thick and calcified. So this is the end of question number 2. Now question number 3. A 40 years male admitted with the complaints of dyspnea, pulse 120 beats per minute, BP 70 by 50 millimeter of mercury, JBP is raised, pulsus paradoxus, present. On auscultation, soft first order sound, and ECG shows low voltage ECG. So what is your diagnosis and how will confirm your diagnosis? And diagnosis is constrictive pericarditis and confirmation by echocardiogram. And possible what is the underlying cause? The commonest cause is tuberculosis, but sometimes bacterial pericarditis, rheumatoid arthritis, and viral pericarditis can do this disease also. Now, what immediate intervention you will take to manage this patient? Surgical resection of the affected pericardium. This is the treatment. Surgical treatment is the treatment of choice. And possible complication is cardiac arrhythmia. Now this is the question number 3. Now 4. A 18 years old boy presented with hypertension, and name 4 underlying cause of this condition. Underlying cause are hypothyroidism, renal artery stenosis, coarctation of the aorta, and pheochromocytoma. Next question, what investigation will do for this group of condition? For hypothyroidism, TSH will increase and T4 will decrease. And for renal artery stenosis, ultrasonography of the kidney shows a small size kidney on the affected site, and CT angiogram of the renal artery to confirm the stenosis. and serum creatinine may increase. X-ray chest preview shows notching of the ribs. ECG shows LVH and echo confirmed diagnosis. And lastly, for pheochromocytoma, 24-hour urinary metanephrine and normetanephrine increased in pheochromocytoma. CT scan of the suprarenal gland showed adrenal tumor. And last question was, what are the effects of long-standing hypertension on heart? The effect of hypertension on heart, one is LVH, which is characterized by dyspnea palpitation, shifting of the apex beat, and bilateral basal capitation. And ischemic heart disease characterized by central chest pain, pain increase after works and relieved by rest, and pain radiate to left arm. MI is characterized by severe central chest pain associated with vomiting and sweating. And atrial fibrillation is characterized by palpitation and irregular pulse. So these are the effects of hypertension on heart. Now the last question of CBS, that is a 50 years old obese patient admitted to hospital with sudden onset of severe chest pain, radiate to left arm. BP was recorded 80 by 40 millimeter of mercury. What is the possible diagnosis? Possible diagnosis is acute MI with cardiogenic shock. Next question, how will investigate this patient? ECG, ST elevation in lead 2, 3 and ABF in inferior MI, and ST elevation in B1 to B6 in acute anterior MI. Cardiac enzyme troponin 1, troponin I increased in acute MI, and CKMB also increased with acute MI. Echocardiograms show akinetic cardiomyopathy, decreased ejection fraction, and LVH. Now the management of MI with cardiogenic shock. Hospitalization of the patient, maintenance of ABC, and tablet ecosprin 75 mg 4 tab start, then 1 tab daily to relieve pain. Injection pethidine 75 mg IM stat and SOS. Thrombolytic agent, injection streptokinase 1.5 million units in 100 ml of normal saline over 1 hour. Injection enoxaparin 40 to 60 mg subcutaneously BD for 5 days. And tablet atorvastatin 10 mg daily. For cardiogenic shock, injection dopamine 400 mg in 5% dextrose 500 cc IV at 8 drops per minute. And we should refer this patient to CCU for further treatment of complications. So this is the end of treatment of acute MI with cardiogenic shock. And with this, we are ending the today's class, and I hope and pray to Almighty God for my students and for their long happy life and free from corona disease. And I will ask them to go on study and take care of their health, and so that they can appear in the next November exam after peaceful recovery of corona attack in Bangladesh. Thank you all.